Hello again. I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. The title for our program tonight is The Quality Issue in Pediatrics. This is a part of the series of productions where we will introduce the so-called clinical champions, the physicians by virtue of their knowledge, their experience, and their integrity will teach us how to define quality services in their special field of expertise. And tonight we have two of those clinical champions in the field of pediatrics, and I would like to introduce them. Our first speaker is Dr. Donna Heicher Conom. Hi, Donna.
Hi.
It's nice seeing you tonight.
Thank you.
Thanks for being here. Dr. Conom is a neonatologist. She takes care of the very sick newborns and infants, and would learn a lot about the field of neonatology from her tonight. Dr. Heicher Conom was a graduate from the Medical School of Missouri and was trained in the field of pediatrics and neonatology in Kapiolani Hospital in Hawaii and also at Valley Medical Center in San Jose. Is that right? Okay. And our second speaker is Dr. Glen Austin. Dr. Austin is a general pediatrician in practice in Los Altos, and he was the former president of the American Academy of Pediatrics in 1981 and 1982. Welcome to our show, Dr. Austin.
Good evening.
We're honored to have you here tonight. So maybe you can, in a few minutes, introduce yourself to our viewer as what you have been doing all these years, Dr. Heicher.
All these years. Well, I went to medical school and then did a pediatric residency at Columbus Children's Hospital, a large children's hospital, and then decided to go into neonatology in Hawaii when I was chief resident. Mm-hmm. We were moving a lot of tiny babies into the children's hospital there, mm-hmm. and did my fellowship partly at USC, actually, mm-hmm. and right. out there.
The field of neonatology is pretty recent, right? You must be one of the first neonatologists.
Well, not one of the very first. I'm probably about the second generation.
I see.
Neonatology started in the 60s.
Yeah.
When we first started ventilating babies, and
yeah.
I got into it about 8-10 years after it actually was started.
Incidentally, did President Kennedy's premature baby had anything to do with the rapid development of the field?
I think so. I think now Patrick Kennedy would survive quite easily, mm-hmm. and with the things that we know now to do for newborns.
That's interesting.
So people say, yes, that the fact that that was a sick baby, a very famous sick baby, mm-hmm. did accelerate neonatology.
Right. It takes mm-hmm. a celebrity baby if that happens. Interesting. Dr. Austin, maybe you can tell us your story.
Oh, it's an interesting story, I guess. I had a degree in public health from the University of California before I went into medicine at Stanford. Mm-hmm. And when I finished my rotating internship and ran out of money, went back to the hills of Kentucky for 2 years in family practice. Oh. And had a fascinating time there. And then went to Cincinnati Children's where I did my pediatric training and fellowship. And then back out to California, which is my home, and have been in practice ever since. Mm-hmm. It's been a very interesting life. Yeah. It's a fun field.
Right. So maybe you can tell us what it's like to go through an average day being a neonatologist first.
Well,
you get up at 5 in the morning?
No, not that early. There is a lot of night work, a lot of because babies are born all hours of the day.
Right.
One of the things we do is stay in the hospital and cover the level 3 and ICU babies, which are the sickest babies.
Right.
And a day there would go from 8 in the morning till 8 the next morning. Mm-hmm. And the first thing we would do is make rounds on the babies and go around to each bedside. The doctor coming off shift would check out to me as the doctor coming on, and we'd go through with the team what the problems are with each particular baby. And then I would come back individually and sit down and think about that baby, think about the problems that the baby's having, and write orders taking care of those problems. If the babies are all stable, then I would pretty much sit around and wait for things to happen. And in a large delivery service, there are babies being born all the time, some of whom need help beginning to breathe, resuscitation. And sometimes the sick babies are not stable. They need our attention.
Right. So I gather most of the sick babies are prematures.
I would say that's the most common thing we see, yes. And
what are the other problems that you see?
sometimes we see infection, larger babies having sepsis, neonatal sepsis, meconium aspiration, aspiration of the fecal material inside the uterus, and the baby gets a pneumonia from that.
Right.
We see congenital anomalies, some that have to be surgically corrected. The very famous one now, the conjoined twins, those are being managed by neonatologists down in San Diego. But there are a lot more common anomalies that can be corrected.
How often are you on call?
I do periods of every third night, 24-hour shifts, but we do that for an 18-day stretch, and then we get almost 2 weeks off to recover.
Oh, I see.
So we found in our group it's best to do, it's better for the continuity of the baby's care.
But how can you be off 2 when you have 5 of you?
There are 6 of us, and we're off that shift, and we're on call for some of our other hospitals. But we found that we do it intensively for a couple, well, actually it's 3 weeks, every third night, 24-hour shifts. And then we give ourselves a breather to sort of recover.
So, I mean, you're in the San Jose area, right?
Yes.
What is the average number of population of people you're serving in your group?
Well, our group serves 15,000 births per year.
15,000 births per year.
Babies born per year in the 5 different hospitals that we cover. And about 5% of them require intensive care.
5%, I see. Now, do I understand right that the mortality, overall mortality in our country is still like 14%, is that it?
Perinatal mortality? No, our mortality rates are down now. I'm not sure exactly, around 8% now.
Oh, really?
Our neonatal mortality rates have really come down in the last few years, mainly because of surfactant, that we now are saving more premature babies.
Oh, I see.
We're still not one of the best ones in the world, but we're...
Oh, that's amazing, though. I mean, because it used to be just a few years ago, maybe 10 years ago, it was 14% or something.
Yeah, we may be talking about different things. Perinatal mortality rates, including stillbirths, is going to be higher than the babies who are born alive.
Oh, I see. Okay. Dr. Austin, maybe you can give us an idea what is the average day of practice like?
Well, let's see. My day started about 3 a.m. with a call from a worried mother with a child with croup. Luckily, it wasn't much of a problem. And then this morning we had our usual pediatric rounds. We have educational meetings every Monday for an hour and discussed hyperactivity and attention deficit disorder. And then to the office, and I've been busy all day in the office. And it's a mix in general pediatrics, from the colds and pneumonias to injuries to the eyes, occasional broken bones and cuts that we have to sew up. But the fun part, I guess, is dealing with the families, the mothers, fathers, and the children. That's what makes it. It isn't a disease. I just as soon do without sick children. I really don't like to have them sick.
What is the percentage of children with behavioral or psychological problems and not purely medical?
Well, they cross so much that I'm not sure you can really make that distinction, although I know they make it. estimates go from 8 to 20%, but I think from a practical standpoint and what we see in the office, probably around 10%.
That's all?
But that doesn't mean that the majority of the population doesn't have its psychological problems at times. And one of our major, I think, focuses is on trying to understand the family and the family dynamics, and by doing this, recognizing that you can't just simply treat the child. You have to know a little bit about the family to be able to put the child in a good position.
Right. Yeah, to me, you know, the pediatricians have a lot of competitions there because a lot of people would consider themselves to be advocates of children. You're talking about family practitioners, you're talking about nurse practitioners, social workers, babysitters. I mean, you know, so many people would think that they would be the best advocates for children. What do you think?
Well, everyone is an expert on telling you how to take care of your baby, for instance, and the advice you get is often flatly contradictory. Interestingly enough, even sometimes between pediatricians. And I think the bottom line on this is that there's a very basic principle involved, and that is, and explains why you get so much differing advice and why so many people think that they're expert. And that's that each and every baby is different. The genetic scientists have calculated on the basis of just the 4 amino acids in the genes that there's a potential of 64 billion unique genetic individuals. And so that they aren't just like General Motors modular products. And that's why the people's impressions are so different. The people that they have seen and helped have responded to one thing, but another group over here has had an entirely different set of, I guess, physiologic, genetic predispositions, and it makes them an entirely different ball game. So you can't just simply, you have to treat everyone as an individual. I'm not worried particularly about having too many advocates for children. I think they need all the advocates they can get. Maybe occasionally they need a swat in the butt too, but that's another and important issue on discipline. But I think that everyone instinctively wants to protect children, wants to help, and so this is fine. We welcome them.
Yeah, providing that they don't contradict each other.
Well, they will continue to contradict each other.
Confusing advices.
But I think that the training that we get in pediatrics, the years of medical school, the years of training in college, and the years of internship and residency, and then in practice, probably set us up better than most to be able to give fairly practical advice.
Yeah. I don't know if I agree with you, because from my own viewpoint, I used to be practicing pediatrics, and I thought I was very poorly prepared to go into practice in the community, because the great part of my practice had to do with stress of motherhood. You know, in how to raise the kid. You know, I mean, you have a lot of nowadays we're talking about a generation of babies who give birth to babies, and that's tremendous pressure from the viewpoint of the practicing physician who have to sort of coach them to raise their kids. I mean, you know.
That's right, and they've lost their grandmothers, and that made a big difference, and this is one of the reasons that a lot of pediatricians have sort of become a surrogate grandparent for the kids, and I think that's not necessarily good. What we really need to do is teach the parents better ways to handle their children. You know, I had the advantage of having 2 years of family practice before I went into pediatrics, and this gave me, I think, a lot more comfort. I would agree with you that a lot of pediatric training in the past has been far too narrow a focus on the rare diseases that are seen in the medical centers, and that isn't what people see outside. And I also agree that one of our major jobs is to help parents parent. But you know, it's kind of spooky. If you start looking at the advice given to parents, it's downright embarrassing, because the pendulum goes back and forth over the years. And if it were a science, maybe. If they were General Motors modular products instead of individual families, maybe. But they aren't, and so that you're going to get all sorts of differing views, differing answers. It's not a simple thing. I think raising children is one of the hardest jobs that exists. Right.
I agree with you, because I look in terms of finding the common denominators of all children. They need to grow. They adapt very. The thing that amazes me about children is their ability to adapt. to different, very strenuous circumstances and continue to not only survive but thrive on those difficulties. And also their sense of optimism. I don't know when they start to lose it, but children can be very optimistic, going through a lot of difficult times, and we have a lot to learn from them, actually. I learn a lot from a very young babies, just observing them. I just, I personally, my own bias is I cannot think of anything more difficult than taking care of a very sick infant. For the nature of the fact that you have, a whole lifestyle, the lifetime of the individual, as a result of what you do. It's not like, if a person, and any individual is precious, but, if a person has lived 80 years, the perspective is a little bit different. What is your feeling about that?
Well, that's what's exciting about it. I think when we're young, that's the appeal of neonatology and the high-tech part of pediatrics is that you can usually turn things around very rapidly, and you usually see, if you do the right things, you can see an instantaneous improvement. And what we're after is normal functioning individuals, and most of the time that is what we end up with. Although the tiny preemies that we're having now and that we're saving do a lot of times have some problems. The biggest problem that we have with them is that most of the time the people that have tiny preemies, not always, but they have some underlying social problem as well. And so the child goes out of the NICU potentially functioning very well, but needs some extra help in terms of early intervention, daycare services, social help for the family to adjust to this. And that's what the pediatrician hopefully does, is integrate this baby into their normal population. And we have a lot of trouble weaning the parents off of all the monitoring and getting them to understand that the illness is over. Now we want the child to be a normal little child, and the pediatricians take care of that end of it.
Well, the interesting thing about normal children that just recently come up is they found that kids under the age of 2 have about 5 times as many neuron synapses in the frontal lobes as adults. And so this brain changes so fantastically during childhood, and it appears that it's a more plastic brain than we used to think. Of course, the other thing I think that makes me feel a little better about all of that is that it turns out that our brain continues to change and actually develop at least through the 3rd decade. And so we aren't over the hill that far.
It just amazes me that we are going down and further down in terms of reviving or taking care of very, very small infants, like 2-pounder, and some of them turn out to be perfectly okay.
Yes, they do.
Which is absolutely amazing, because I think that part of the wonder of children and young infants is that their cells are still fresh. Once it's just amazing me before that once you put a tube in, you just put a few blow and oxygenate the lungs, things change very rapidly. But again, it's very at once exciting and very challenging, because the few minutes that you have can make a whole difference in the world in terms of having a very damaged baby or a healthy one.
That's right. We have to plan when the baby is still inside the mother in utero to be aggressive about the resuscitation and the rest of the baby's care. If there's a half-hearted planning for that, usually things don't turn out as well. The best way to transport the neonate, tiny preemie, to the intensive care unit is still inside the mom.
Right.
So if the delivery is controlled, if the perinatologists get to prevent, basically, if the perinatologist could put me out of business, that would be fine, if they could prevent prematurity.
So talking about prevention of prematurity, are we ahead in any way? Because that has been a very difficult subject of studies and research.
Yeah, I think that's still the big challenge. We would like to see all babies born with mature lungs and with mature organ systems, because a certain percentage of these tiny preemies who survive are handicapped in some way. And so the best thing would be to keep the baby inside the mother until term. There are a lot of things being done by the perinatology experts, the OBs side of it, to prevent prematurity. But I think that we still have a long way to go, and getting back to the social side of things, a lot of this is just lack of prenatal care.
Okay.
Things like that, where the mother doesn't take good care of herself, or she does drugs, for instance, and she really has the cards stacked against her in that situation.
Just you know, by way of statistics, we're spending $1 trillion annually on medical care, and 1 out of 4 pregnant women in America still don't have any adequate prenatal care. You know that?
I believe that.
I mean, that is.
Isn't that amazing? And you know that on prevention, which is the name of the game, that $1 invested in immunizations saves $10 in long term.
Right, right.
And yet people don't really pay much attention to it. And it turns out that a single day in the hospital for a child costs more than the entire preventive care for their first 21 years of life. And yet we have real difficulty convincing many in the health insurance industry that preventive care is worthwhile.
Yeah.
And we know, those of us in practice, that we keep these children out of the hospital. It's difficult to prove with the kind of numbers that they want, but we know it happens.
Okay, why, you know, I mean, we don't practice prevention. I mean, we have known for ages that an ounce of prevention is worth a pound of cure, so why don't we practice it?
It's because American health insurance industry seems to concentrate on this quarter, and the preventive response doesn't come about for maybe, what, 10 years?
It doesn't make money to prevent.
It doesn't make money tomorrow.
Okay.
And Americans, our business is so focused on this, and this is one of the things that has created some of the problems that we've had with medical economics, because they are so interested in today that they refuse to look beyond the end of their noses.
Yeah.
I think some of the government programs do understand, though, that if you improve prenatal care, you can decrease the amount of money you spend on NICU, neonatal intensive care unit days. For instance, the Medi-Cal program, they're enlarging the prenatal programs and trying to. I just think that we have a lot of cultural barriers and social barriers to problems with access to physicians, even in Santa Clara County.
So I mean, the large amount of money we spend are not in the right place. That's what you're saying?
Right, right. It takes quite often $500,000 to save the tiniest preemies. Wow. That's what it costs in hospital charges. That's not necessarily what the hospital collects, but they're very expensive little babies. Yeah. Although you can't buy a house for that. I suppose our value system should be such that we try to save a child that has 80 years of productive life ahead of them, rather than spending it at the end of life, which is, we know we spend a lot of money in care at the end of life, which isn't really productive either.
It's just the thought I have is that in my own understanding of the situation is that the reason we don't do prevention as much as we do cure is because cure makes money. And one angioplasty, for example, feeds 10 people. You know, and it doesn't, make much money trying to motivate people to, eat the right kind of diet or exercise. That's not a job of the medical profession, I guess. That is the, the exercise guru or something.
Well, it's also difficult to convince a lot of people, at least, of the value of prevention, because there isn't the discomfort that drives you in to get medical care. And it's much easier to spend your money on other things, a new video or whatever, than it is to get your kid in to check over when you think they're healthy, to see whether or not they might have a problem. And actually there are families that refuse to bring their children in because underneath it all, emotionally, they're worried that you might find something bad. And really, it's kind of interesting to see why people don't take advantage of preventive care. part of it is the money, and part of it is the fact that it's harder to drive yourself, to discipline yourself, to be able to do preventive care. Just as hard to get up in the morning and go jogging sometimes.
Yeah.
At least it is for me.
Yeah, actually one of my guest speakers who came from Columbia University, he specializes, he wrote a few books on nutrition. He mentioned that it was amazing how we would take better care of our cars or our pets than take care of our own bodies.
Right.
You know, we don't put the wrong fuel into a Mercedes or a Rolls Royce, but you eat all sort of junk, you know, and feed your own body with junk food, you know. So it's, I think that's why I'm really hoping through mass media like shows like this, you know, we have to sort of repeatedly giving the same signals and same information about the same thing, you know, prevention, whatever.
And it's interesting that the adolescents, of course, have this sort of sense of immortality, that nothing can really bad happen to them. And actually, to a degree, it carries over sometimes into parenting, and nothing really bad can happen to my child. While there are other parents, often the ones that have been, I think, nailed, like with a preemie, who become exceptionally sensitized, and then they become over cautious and over anxious and create problems from that. So it's a mixed bag, but prevention is a hard sell, even when people know logically that it does help. It's something that they aren't driven to do as much, and so part of it is because of the insurance industry that didn't believe in prevention. All I believed in was catastrophic insurance, the sinking of the Titanic. And if a baby is coming into neonatology, but when it comes down to the routine care that they need, it might pick up the preventable scoliosis or the early kidney disease that would lead to hypertension later. So many things that we can find and hope not to, but we can affect and can have a positive effect by using these. And that's really part of what quality care is about.
I'm sorry, but we have to wrap up now. We are finishing the first part of our show. Quality issue in pediatrics. I'm Dr. Vu. This is America's Healthcare Crisis. We would like to welcome you to the second part of the same production, show 40, and we will invite both our speakers, Dr. Heicher and Dr. Austin, back for the next segment of our shows. Thank you for watching. I'm Dr. Vu. Good night.
Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Do you have someone to stay through the years? Let me be the one. Now that I am here, let me be the one to be there with you through the hail and snow, so our love will grow. Let me be the one in the morning sun or the pouring rain.